Khatib.
Thank you for the opportunity. So, I have basically two cases where I've shown, where we can do a transepithelial PTK in really bad LASIK complications. Okay, so this was a 35-year-old female. She had LASIK done elsewhere 6 months back. The right eye was okay, 6 by 6. The left eye was uncorrected, only 6 by 36. And this is her refraction, -2 with -2.5 cylinder. And on acceptance, she just had a -2.5 diopter sphere. She was only improving to 6 by 18 in the left eye. Her contrast sensitivity also was much lower than normal. So if we look at the right eye post-op topography, this shows a good, topography consistent with a myopic LASIK with a good central flattening. But if we look at the left eye, you can see that this is not consistent with a myopic LASIK ablation. So you've got some kind of central steepening over there. And this is not ectasia because the pachymetry and all is normal. So what could have gone wrong here? If you look at the epithelial maps, which is something very important in today's time, the right eye epithelial map is consistent with a myopic LASIK, but the left eye you can see an abrupt thinning in the center. So when we look at the raw image of the OCT, on right eye we can actually trace the flap here. It's like a meniscus flap. And if we look at the left eye, we can see that in the center the flap is diffusing with the epithelium. So this most likely must have been a buttonhole, which may have happened, and the surgeon may have just gone ahead with doing the LASIK, and what happens is that when there's a buttonhole, there's a central stromal island that is left behind, and the epithelial tries to compensate for it, but because of the bump, the epithelium is thin in the center. So in our case also, we saw abrupt thinning in the center and then adjacent thickening. So this was basically a buttonhole which now needed to be repaired. So whenever we have a buttonhole kind of situation where we've got a stromal bump, the only way we can treat this condition is if we remove the stromal bump. And the only way to remove the stromal bump is if we go all the way down, and this can be achieved by a transepithelial PTK. So if we do a PTK of the maximum epithelial thickness, we'll eliminate that bump. But then what also happens is that it is uniformly eliminated from all throughout. So you will get stromal ablation in the periphery. So we went ahead with a transepithelial PTK in this patient, explaining that you will require another procedure for refractive correction later. Right now we are not removing your number. So we did a 65 micron transepithelial PTK. And this is 2 months post PTK. As expected, we've got a residual sphere and cylinder, but the best corrected vision has improved to 6 by 12 now. And this is post-op 5 months. Now we can see the epithelium is, become fairly regularized, almost 50 microns everywhere. And now she's got a refraction of -3 with -1.25, with the best corrected vision improving to 6 by 9. And this is the topography post PTK. So we can see it's not an absolutely regular topography, but it's kind of better than what it was pre-PTK. Now, once we are satisfied that it is regular, now we will go ahead with doing another PTK with a refractive correction, and this will be a topo-guided refractive correction. So we did a 50 micron transepithelial PTK, and then we did a topo-guided treatment. And now post-operative 2 months, she's 6 by 9 unaided, and the topography looks fairly regular. And best corrected 6 by 6, and she's improving. Her contrast sensitivity has also now gone up. So these were 2 treatments done over a period of almost 7-8 months post LASIK, where she has improved now. This is another case, a bad case. A 33-year-old male operated for LASIK 9 months elsewhere. Pre-LASIK number was right eye -2.5, left eye -1. So left eye was done normally, but the patient says right eye surgery was aborted due to some flap-related complication. And right eye treatment was done with PRK 5 months back, that is 4 months after primary surgery. And the right eye had poor vision, no improvement. Again, right eye uncorrected vision is 6 by 36 partial. Autoref is showing a high cylinder, -5 cylinder in the right eye. And look at the right eye, there's a lot of scarring, and you can see a epithelial breakdown in the center. You can see a crab claw kind of appearance on topography. Epithelial map is very irregular. You can see a lot of hypertrophied areas of epithelium. And why the epithelium is hypertrophied, if we do a OCT raw image passing through the scarred area, we can see that because of that scarring, there is a flattening induced in that area, and the epithelium is trying to compensate and thickening. Similarly, we are seeing this. So our plan was, we again told the patient that you will require more than one procedure. We went ahead and did a transepithelial PTK of 100 microns so that we could go below the scar. And the idea was once we, ablate the scar, at least we are going to somehow negate that flattening which is caused because of the scar. So pre-op, this is post-op 3 months, and you can see post-op 1 year, the epithelium looks much better than what it was before. And when the epithelium is regular, we know that the surface below has become quite regular. And these are the pre and post 1 year follow-up raw OCT images. We can see that scarring has become quite less. And now we can see in the post-op 1 year a rim of scarring around, and that happens because we've removed stroma from that area. The refraction has not changed much, but subjectively he's improving to 6/9 with a +1 -3 diopter cylinder at 165. So the topography now is quite regular, and we decided to do a phakic lens surgery to remove the refractive error. And now post the phakic lens patient is 6/9 unaided. Contrast sensitivity is not great, but it is much better than before. So basically, I just wanted to show two cases where, cases which seem quite bad and non-salvageable, with transepithelial PTK, we can actually kind of, make the situation better. Thank you.
That's great. In the first case, you have removed whole the epithelium again, PTK.
Yes, sir.
We can have a selective PTK also. Or we can just do it manually in the central part. I think that also helps a lot. That gives you more regularity compared to if you did a PTK as such.
So the idea was that with that PTK to remove the stroma as well in the center. If we would do a manual...
some ablation also, stromal part.
Yeah, because we wanted to remove that stromal bump which is there. So that is why we use transepi. If we would have done manually, then the bump would have stayed. Right. And then we would not be able to do a treatment after that. It would again regrow the same way. So the idea was to regularize the stromal surface with the transepithelial PTK.
Right.
Sir, thank you.
Good morning, everyone. Thank you so much for the opportunity.